Welcome to the Baptist Health Doc to Doc podcast, a conversation for physicians by physicians, providing insight on the latest in medical practice, research, technology, and innovation in healthcare on the Doc to Doc podcast.
Even with the success to reduce smoking, lung cancer remains the leading cause of cancer deaths worldwide for both men and women. In 2023, there were approximately 238,000 new lung cancers and 125,000 deaths in the United States alone. Efforts to improve outcomes have not only led to greater understanding of biology and genetics of lung cancer, but also the individual lung tumors. In recent decades, the evolution of robotic-assisted thoracic surgery has enhanced primary lung cancer treatment and postoperative outcomes. That, in combination with advances in immunotherapy and our understanding of the cancer's molecular biology, bring many tools to the battle against the leading cause of lung cancer deaths in the United States. I'm Dr. Paul Kaywin. I am a thoracic medical oncologist at the Miami Cancer Institute, also a part of Baptist Health South Florida. Sitting next to me is Dr. Mark Dylewski, who will introduce himself.
Hello, I'm the Chief of Thoracic Surgery at Baptist Health Systems.
Yeah, so Mark, maybe we can chat a little bit about our approach to managing and diagnosing and treating lung cancer at Miami Cancer Institute. What are your thoughts when you first see a patient?
Well, that's a very interesting question. I think that we should start a little bit about how things have changed in a very short period of time. I think in the last 3 to 5 years, there's been dramatic advancements, not only in the surgical fields, but also in the medical oncology fields and in radiation oncology fields. And we'll go through that today. But just to point out, in the past, many patients who presented with lung cancer, despite the various stages, would generally be seen by an individual, either a surgeon or a medical oncologist, and often there wasn't collaboration between the specialties. And we've made it a very important point or part of our treatment algorithm that virtually every patient that presents to MCI is handled in a multidisciplinary fashion where the experts within the field of treating lung cancer have an input in every individual case.
Yeah, I agree completely. I think multidisciplinary is really the key word here. And we collaborate very closely together also with our radiation oncology colleagues. And a big part of that is our thoracic tumor board that we have once a week.
So Paul, let me ask you, what do you think is the importance and why treat patients who present with complicated lung cancers in a multidisciplinary fashion? What does that bring to the value of the treatment?
Well, each patient's journey with lung cancer is very individual. Every cancer is somewhat different. And our philosophy at Miami Cancer Institute is to guide treatments. We often use the word precision medicine. We guide treatments to want to know what is their type of lung cancer, what is their stage of lung cancer, and what are the specifics about their cancer. And then we conference together to make the best decision. Is this a patient that it's best treated with initial surgery, or is it a patient that's best treated with initial medication treatment or with radiation or a combination? So it's very important that the three disciplines talk to each other and evaluate each patient individually.
So when I was in medical school and residency, I was taught that there were basically 4 types of lung cancer. So earlier in your statement, you said every patient is different. So how is everybody different? It's what explains the variety of tumors and how every patient should be treated as an individual and not as a group? When we were first in training, the basic decisions about lung cancer treatment were based on histology, the type. So we know there are subtypes of lung cancer, broadly small cell, non-small cell, and then within non-small cell, histologically, the main types being adenocarcinoma and squamous carcinoma. And that guides us in terms of different treatments, especially from a medical oncology point of view. Certain medicines are better for one histology or the other.
But what's transformed the treatment from a medical oncologist point of view, to answer your question more specifically, is basic research that's been done to get more information about each person's type of cancer. So in year 2000, the human genome was sequenced, DNA sequenced, and a particular technique called Sanger. But by 2004, what is now called next generation sequencing became available, which made the ability to quickly and cheaply sequence DNA. So we can now take everybody's lung cancer, either by a specimen from a biopsy, which you may have done, or some cancers shed their DNA in the blood, and we can sequence the DNA of that cancer to detect mutations. And we know that lung cancers have many mutations, but some mutations are what we call actionable mutations. These are not genetic mutations that are inherited. They're spontaneous mutations that develop in normal lung cells to sort of make them or drive them to be cancer cells. So these are driver mutations, and it's very, very important now. Every person with lung cancer that's diagnosed at Miami Cancer Institute gets next-generation DNA sequencing to see if they have particular driver mutations, because that would guide me as a medical oncologist as to what specific type of treatment may be best. In addition to these driver mutations, we can pick up a test called a PDL1 that gives me information as to whether the cancer may respond to immunotherapy. So the weapons that I have to treat cancers with medicines, chemotherapy, immune therapy, and targeted biological therapy are available. And what I need to do as a medical oncologist, and what we do multidisciplinary-wise, is to take that into consideration to say what would be the best medical treatment for that person. Now, from your point of view, there have certainly been huge changes during your career about techniques for surgery. So tell me a little bit about your journey, how you got into robotic surgery, and you're one of the country's leading teachers for robotic surgery. You train other doctors. What's that all about?
So yes, you're absolutely correct. I've been practicing a little over 20 years now, but things have changed so dramatic since I originally went through residency program. In the early days, we used to do these surgical procedures through a very invasive open approach, through big incisions, spreading the rib cage, cutting all the muscles, so that we could actually put our hands inside the chest and do what we were tasked to do throughout the operation. For instance, doing a lobectomy for lung cancer. And then about 15 years ago, we started toiling around with small instruments, handheld instruments on long shafts, where we'd put them through small ports and try to replicate what we do as an open surgeon. But it wasn't always adaptable to most surgeons. In fact, only a very small percentage, about 30% of surgeons, were able to accomplish the same level of surgery through what we call a video-assisted approach that you could do through an open approach. But what has happened in the last decade or so is, many of you have probably heard about robotics. It's happening in all aspects of our human life, in building automobiles and all kinds of robotic-assisted procedures. Well, it has entered the field of surgery. It's basically a system that we control as the surgeon, but we're actually external to the operative field. We sit at a chair like this, sit in an immersed field using a video headset and some glove-like hand instruments that we put our fingers in, and we're able to actually control instruments that are placed through small pencil-sized ports inside the rib cage, and the tips of those instruments function just like a human hand. So you can have a grasper in there, and you can have 7 degrees of rotation and flexion, and you can grab and cauterize and cut and do all kinds of delicate maneuvers in very tiny, tiny spaces. And we've learned that this technology allows us to essentially replicate what we do through an open approach, but through a completely minimally invasive approach, which has had a dramatic effect on the early recovery of patients, the complications associated with post-surgical patients, and it has made a big improvement in how we operate on patients, what risk factors apply to surgical patients nowadays. And when I mention risk factors, you can remember, we've been working together for 20 years, and you can remember patients who present with very advanced stages, stage 3 disease with very large tumors, bulky lymph nodes in the mediastinum. And those folks we used to treat with a multimodality approach with chemotherapy and radiation, and then offer them surgery. And those folks would often go to surgery through an open approach and had a very difficult time in the hospital recovering for several weeks. And then after they left the hospital, they'd have many more weeks of recovery, and they'd be debilitated after the complex surgery and chemo and radiation therapies that we offer them. I believe you've witnessed the changes that have occurred with respect to how these patients respond to surgery. They do very well after surgery. It's usually an overnight stay in the hospital nowadays, and we send them home after the patient has received their upfront therapy. Now, nowadays, we don't utilize radiation as much, and it would be interesting to tell the audience why we've made that change and how the immunotherapies and the targeted therapies have sort of altered our methodology of treating these patients.
Yeah. And just by the way, so when you're doing your robotic surgery compared to the old days, do you see things better? Does it give you actually better? You're looking at a TV screen where things are magnified?
Absolutely. You see 3D vision, and it's magnified by tenfold. So in fact, you can see even, small layers of tissue through the robotic camera that you would never be able to see with your own eyes. You'd have to wear a headset to magnify it, so you can see very precisely the tissue layers that you're dissecting through. There's also augmented type of adjunctive devices on the robot that allow you to, say, identify the vasculature. We can pull up a CT rendition of three-dimensional reconstruction of the vessels inside the camera that we can sort of set off to the side and utilize that to sort of identify the anatomy while we're working. And the advancements in that, development is ongoing. Every other 6 months or so, they come up with a new adjunctive therapy. So it's made our ability to do surgery on much higher risk patients, much older patients, very safely with very low complication rates.
Yeah, and I would definitely agree. And I remember the old days where someone would come to see me post-operatively from surgery, and they'd have a huge incision across their thorax, and now they come and they have a few small little incisions, and they've had surgery a week before, and they're up and around. So it's quite amazing. I would definitely agree. So to answer your question from before, as we talked about, multidisciplinary is sort of the watchword, and with the treatments that I have as a medical oncologist, as I mentioned, chemotherapy, immunotherapy, targeted therapy, those treatments were developed in people with advanced lung cancers, what we call stage 4. And in those cancers, these treatments are not curative. If someone has an advanced lung cancer, stage 4 metastatic lung cancer, these treatments can be very effective to induce a remission, to control the cancer, oftentimes for many years, but they're not necessarily curative. So the thought process then in terms of the research for lung cancer is, well, if we have treatments that are effective in the advanced setting, what about moving them earlier to earlier stage lung cancers? And we know that even in people that are operated on for early stage lung cancer, the curability relates to the stage. So a small stage 1 lung cancer, for example, has a high cure rate just with surgery alone, and those people we often just observe. But as the stage gets higher, larger stage 1, stage 2, stage 3, there's significant risk for those people to have a recurrence of their cancer even after surgery. So now we know through clinical trials that have been done over the years that postoperative treatments with targeted therapy if their cancer has a mutation, or immune therapy or chemotherapy, or sometimes a combination after surgery, can improve the cure rates. And there's ongoing clinical trials to try to do even better. So then the thought process says, well, if we have treatments that we know can achieve remissions in the advanced stage, and we have treatments that can improve the cure rate in the postoperative setting, what about putting those treatments before surgery? And the term that we use is neoadjuvant, before the surgery. And clinical trials have been done, and now you and I discuss patients all the time at Tumor Board where they may present with a cancer that is potentially resectable, but that it makes sense to consider giving them initial treatment with chemotherapy and immunotherapy that may help to downsize or downstage of the cancer, that may make your surgery easier. But more important, what's been shown is that in many of those people, after surgery is done and the specimens are looked at, when they've had chemotherapy and immunotherapy ahead of time, that some of those cancers have achieved what we call a pathologic complete remission, where under the microscope it just doesn't look like there's any living viable cancer. And in those people, we certainly hope that having this neoadjuvant, this upfront chemotherapy, immunotherapy, may be successful to even improve the cure rate above and beyond just surgery alone. So these are the issues that we talk about and discuss all the time at our tumor boards, and our radiation colleagues are not here today, but they also play a big role in making some of these decisions as to what would be the best cancer treatment.
So what I'd like to talk a little bit about is, it's easy to address patients that present to us with a tumor in the lung that's been discovered for whatever reason. They developed symptoms, or they received a chest x-ray for another reason and was found to have a large mass within it. But what about talking about the patients at risk? I mean, how do we educate our referring physicians, our medical community, the patients at large, as to what would be appropriate screening modalities to encourage patients to have in order to catch them in their earliest of phases? I think you would agree that the earlier you catch the tumors, the bigger impact that you'll have on improving their survival and long-term cure. And so how do we go about educating our referring physicians, our medical community, and the patients out there?
Yeah, and you've been a big part of the initiative that we have in Baptist Health, along with our radiologists, to set up what we call lung cancer screening program. And so certainly we know 85% or so of lung cancers are related to cigarette smoking, so that clearly is our target population. And there have been a series of worldwide clinical trials done showing that doing a low-dose CT scan in people at risk, people 50 years older who have had a significant smoking history, if they're screened, that we can detect these cancers earlier and then increase the cure rate for that.
Absolutely, you're absolutely correct. And what's so insightful in the national and the international trials with respect to lung screening is how the survival and the curability is improved when a tumor is caught in its earlier stages on a lung screening, as opposed to the data that would suggest that the curability after someone presents with a symptom and are undergoing screening CT scans at that point and are still found to have an early stage lesion. In a symptomatic patient that's found to have stage 1 cancer compared to someone who's incidentally found to have a stage 1 cancer on lung screening, the survival almost increases by 10% when they're treated appropriately. So that's really important to convey to our medical community and the patients at large, that if you have those risk factors, you should undergo an appropriate screening CT scan and maintain that on an annual basis. Because if you're unfortunate enough to be discovered to have a pulmonary nodule, the impact that a lung screening study will have on the ability to cure that patient is going to be significantly higher than if you present when you develop symptoms. It also has the benefit of reducing the overall cost of society in treating patients with lung cancer, because you can imagine if a patient who's a smoker that doesn't seek out lung screening and eventually present with stage 2 or stage 3 disease, talk a little bit about the cost to society compared to someone who we treat with early stage disease.
Yeah. I mean, it's absolutely a very important point. Not only in terms of screening, but at our institution, Baptist Health and Miami Cancer Institute, we have lung screening programs that our listeners, if they're physicians listening to this podcast, should avail themselves. Any doctor can send a patient for a lung cancer screening. And we also have smoking cessation programs that are available for people, since we know that smoking is such a risk factor. Back before the 1900s, lung cancer was rare. It's only been really since cigarette smoking that the lung cancer has exploded. It kind of peaked in the 1980s. Remember, the Surgeon General report linking cigarettes to lung cancer was in 1964. And after that, society jumped in to try and really make the public aware of the risks of cigarette smoking. Cigarette commercials were taken off the air on TV shows, for example, in 1970. So lung cancer incidence has been trailing lower since the 1980s, but it still remains the number one cause of cancer deaths as well. So looking ahead, what do you see as possibly some of the advances that might be coming along in terms of from the surgical point of view that you might be interested in letting our listeners know about?
Well, that's a very intriguing question, and there's a number of advances in the field of surgery. I think those advances are sort of dovetailing into what people believe, or physicians or researchers believe, the future treatment of lung cancer is going to amount to. And take, for instance, a patient with early stage lung cancer. Those patients would typically undergo surgery done in a minimally invasive fashion, usually with robotics nowadays. But there's some thought process that with the advancements of targeted therapy, with the advancements of genetic analysis of the tumor, perhaps maybe just a biopsy to get enough tissue to do the genetic testing. And then if we discover that the patient's tumor has a particular marker, it may be readily treated with a targeted therapy and not require any type of surgical intervention, or maybe add radiation to that following upfront immunotherapy. And that's the sort of the thought process as to where the science going with respect to invasive treatments of lung cancer. I think surgery is always going to be around. We always see those tumors that just don't get a complete pathological response with upfront therapy, and those patients are ultimately going to need surgery. But I do believe that moving away from more invasive procedures and treatments is going to be where we're heading with the treatment of lung cancer.
Yeah, and looking ahead from my perspective, and certainly the initiatives at the Miami Cancer Institute in terms of clinical trials for medical oncology are very important. That's how we make advances. Science is real, and the basic science research are where we make some of our biggest advances in terms of understanding lung cancer treatments, and putting some of the treatments that are available or newer ones that are being developed to target cancers, and to find many of the lung cancers that we see have mutations, but the mutations don't yet have a treatment. So we're looking forward to more research to be able to target those mutations as well. So wrapping up a little bit, maybe we can summarize where we stand. That The field of innovation and research continues, and with it, the hope for millions in the future. As these proven advances come into view, we will continue to bring the best treatments for all of our patients and advance the knowledge base for our colleagues. So, Mark, it was a pleasure talking to you today on this podcast.
Thank you for the opportunity to participate in the podcast. I really enjoyed it.
To find out more about the topics covered on the Doc to Doc podcast, please visit physicianresources.baptisthealth.net.